this morning is a little bit more practically orientated. I'm not going to be showing you any flashy videos, because when you see a laparoscopic video or even a laparoscopic demonstration, you're seeing something which has been highly refined and highly edited for your consumption. And the truth is that with laparoscopy, as with any other type of surgery, there are some very practical considerations. It doesn't always look elegant, and you need to know that. Because one of the things that people find when they first start out is they get a little intimidated by people like Indy Gill, who comes and does a fantastic operation, and think, oh my God, I will never be able to do that. Well, you will, and it's just a matter of time. But in the meantime, you have to devise the way that you're going to get from here to there, and it won't happen straight away. So this morning is a little bit about that, how you get from here to there. Well, the first thing you must do is to train, and this is the laparoscopic training course which we've held in Leeds, where I first learned laparoscopy, and this was in 2001. And a few characters here. This is endoscopic surgeons, and it's very important to actually make use of people, either by going to courses or people in your local hospital who actually already do laparoscopy. And if you're a urologist, you work in a general hospital, perhaps where there is many general surgeons who are doing laparoscopy. And it's very difficult when you're established consultant to do this, but it's very useful to go along and assist your colleague to do a laparoscopic cholecystectomy. It will be very instructive to see how he sets up the operating theatre, to see how he uses his assistants, to see how he is familiar with his instrumentation. And these are all the things you have to do, so go and work and assist an established laparoscopist. And the people who are most likely to be there are your gynecological colleagues or your general surgical colleagues. And equally, you can use both. If you're going to do some pelvic surgery, we'll go and assist your gynecologist doing some endometriosis, for example, or doing a lap-assisted hysterectomy, or an oophorectomy, or something like this. Or go and see your general surgeons doing some upper GI work, a Nissen's fundoplication, or a laparoscopic cholecystectomy. These are happening in hospitals all over the place. They are there. I think it is difficult when you're a consultant to go and take part in an operation from a colleague. But swallow your pride and do it, because that's a very good way to learn. And it's available on your doorstep. You don't have to travel miles to come to a course to see this kind of thing. A few things about instruments, because a lot of people at laparoscopic courses will come along, and there's been a little bit of it here. Fortunately, I think not very much. And certainly at meetings will come along with huge selections of instruments, massive selections of instruments, to try and entice you to spend your hospital's money with their company. And I'd like you to ignore them, okay? I'd like you to ignore them, because you will be misled, and unless you've started laparoscopy, you will buy things that you do not need. And then when you do need an instrument later on, the manager will say to you, well, you've used up the money, there's none left, I'm very sorry, which will be a shame. But let's start off looking at a few basic things. And as I have to tell you, and it's not a plug for the company, but when I started laparoscopic surgery, Storz loaned me a set of instruments. A very basic set of instruments, including 4 ports, a telescope, and about half a dozen 6 hand instruments. And when the hospital could afford it and they were convinced that laparoscopy was a good thing, they bought the same set for me. And these are the instruments that I use for almost every operation that I've done in laparoscopic surgery. And I haven't felt the need to buy lots of others. As I was saying to some of you the other day, the surgeon may choose to do 2 things. You may either choose to learn the repertoire of instruments and use different instruments for each task. Okay, fair enough. But when you end up in a foreign country doing an operation and your instruments aren't there, you'll be stuck. Or you can learn the basic techniques of surgery which you can apply with any instruments. And I think for the purists amongst us, that's the way we must do it. We must learn how to use laparoscopic instruments and not worry too much about the different types and the sophistication. Take some basic instruments and just learn how to do it. And on top of that, when you have time, when you have money, when you have experience and ability, you can then start to refine your types of instruments, but you need to learn the very basic things first. So these are the things that I use. This is a 5mm port in children. I tend to use these. These are distorter ports. Inside the port you can actually take it apart. Sometimes the representatives don't like me doing that. But inside the port there's a simple dustbin lid. And take one of these apart, okay? There's a little dustbin lid. And as you put the instrument or the trocar through, it just opens it like this. It's a very elegant little mechanism and it works very well. There's a tap on the side, and the tap is to deliver the... What we can do here. Okay, don't worry, I'll do one of these. Here we go, here's the port. There's a tap on the side, and this tap has got a Lure lock connection, and that's for the purposes of connecting the gas. But you can also use it if you want to flush the port with some saline, or you can also use it to aspirate. You very rarely have to do that, frankly. You're using this to connect your CO2. Now, beware, instruments with ports are a problem, with connectors are a problem, because if, when you're in there, you're looking around, and everything goes flat, because the neuroperitoneum is being lost, just bear in mind that one of the commonest causes is the taps open. Okay? You've either manipulated it inadvertently, your assistant's opened it, or the nurse has handed you a port where the tap is open. Now there's various seals on this which you need to know about. You see around here the little plunger, that little lever there, pressed by this handle, that is what opens the dustbin lid. If I open the port, I'll show you. That's okay. You see this little lever here? As you depress the handle, there you are, there's the dustbin lid, it opens. It's got a nice little rubber seal. And the technology of this little instrument, although it's been around for a very long time, is really quite fantastic. And you can see that around each of these little things is a rubber seal. You see the rubber seal there? Well, that can be a cause of loss of neuroperitoneum if that seal is broken. And of course, with time made of rubber, it will go. Around the top of the instrument, right, the insertion site, is another rubber seal. And you can see that this is a washer that fits over the end of the instrument. You can take it off. Okay? And it's replaceable. And this is a nice one, it's working perfectly fine. But around the circumference there, you see it's nice and smooth, like one of those mints with a hole in it, but it can split. Okay? It either doesn't fit around your instrument snugly, or it splits, and the gas can leak out of there. So this is all, this is a nice little piece of kit, and when it's working well, it's fantastic. When it's not working well, you need to know how it works, so that you can take it apart, replace the washers, and make it work. Alternatively, you can use a disposable port. Some people choose to do that because there's no initial expense, except for every case you have to spend a lot of money actually for the instruments as you use them. But some hospitals allow you to do that more than buying a lot of instruments or an expensive group of instruments at the beginning. They will allow you to use disposable instruments, and you have to negotiate that with your managers. Now, down the middle of the port is the trocar. This point, or a version of this point, is responsible for the majority of severe laparoscopic injuries, and certainly most of the fatalities. Alright? It's incredibly dangerous. And the danger is not so much in the point itself, although of course it's very sharp. The danger is the person using it. Now, when you put the port in, and I'll you this in a moment. When you put the first port in, I would advise that you always do everything under vision. So when you're manipulating sharp objects inside the cavity, you always see it. So that when you're placing your first port, I actually remove this, and I place it without the trocar through an open technique, which you saw me do the other day. We had a little problem with the instruments, the forceps in particular, and that's why it looks a bit clumsy, but you place it open, you make an incision in an abdominal laparoscopy below the umbilicus, and you go directly through the fascia and through the peritoneum, and you place this directly in. And this isn't going to injure anything, okay? It's going to be perfectly safe. And then when you're in there, you've got your pneumoperitoneum, you want to place the additional ports, you use these, and you use these to coax this way through the muscle, through the peritoneum, and directly into the abdomen. You saw in my videos, I think on Saturday, the placement of the additional ports under vision from the camera through the abdominal wall. Okay, so anyway, that's quite a lot about the ports, and it's a very sophisticated piece of kit, and when it works well. Now the camera and the telescope. Let's talk about the telescope. The telescope comes in different shapes and sizes. And let's try and show you this. I don't think it's going to help. Okay. Let's just put that down for a moment. This is a 5-degree telescope, and this enables me to use these 5mm ports in children. It's actually a very good telescope. It's similar to a cystoscope. It's got a Hopkins rod lens system in it, and that means if you bend it, you break the lens and the thing is useless. So you have to be careful, but it's a very nice instrument indeed, and it gives you very nice pictures. And Storz improved the technology of this about 5 years ago, to the extent that this gives as good a picture as the 10mm laparoscope. However, for the majority of you, I would suggest a straightforward 10mm telescope will be fine. My colleague Azad Najmani in 1993 started laparoscopy with a 10mm scope, and he still uses it today. Okay, so that's 11 years of good use, of very good use, and so it was an excellent investment. You just need one, probably two good telescopes, and they'll last you a long time. Now, at the end, you may either look straight ahead, the so-called 0-degree scope, or you may look slightly downwards, as in all cystoscopes. And if you have a downward-looking scope of 30 or 70 degrees, it enables you to lift the scope above where you're working. I have to say, practically speaking, it's more difficult to orientate with an angled scope. So you have to buy a 0-degree scope. This is the most useful size, and if you can, buy a 5mm 0-degree scope, because this is a strong instrument. It delivers a lot of light, and it's very flexible because it will fit down all of your ports, the 5mm and the 10mm ports equally. Now look, this is my instruments, and these are the ones that I use for pretty well everything. Now, they gave me these big graspers, and I don't use them for children, but what I do use is some Kelly curved dissectors, 2 of those, the diathermy hook, the man-knee graspers. These have a nice jaw which allows you to reach around things. So if you want to lift up a pedicle, you can reach around rather like an Alice forceps and lift it up. And these are the Storz scissors, and these instruments all work very well, and they've saved me a lot of money in terms of disposables. If we look at one of them, the instruments, have we lost it? Do you have any video on yours? Can someone just... Oh, here we go. So that's good. Thank you very much. The instrument comprises several parts. Here we can see there's the handle, and on the handle we have various attachments here. This is just a straight offset scissors, which are very good, and it's a fairly standard configuration for the laparoscopic instrument. Here we have the connection for the diathermy, so that your instrument can become an active instrument at any time. This is very helpful. Of course, you have to remember which instrument the diathermy is connected to, but that's also very important. And I would suggest you try to limit the diathermy to your right hand. Your right hand, for the most part of the operations, is your active hand. This is the quick release mechanism. To take the instrument apart, you click on that, you open the handle, and it comes out. Okay? Inside here there's little washers, and when these washers go with time, they need replacing, because that causes failure of your instrument. Now, I'll just put it back together again. Most laparoscopic instruments also have two other features. The reusable ones, the reusable ones have this little cap here, and it's made of rubber and it's disposable. And another cause of loss of pneumoperitoneum is when the nurse hands it to you with this open. Okay? And actually, if you're quiet in the theatre, and in many theatres it's quite noisy, but you can actually hear it whistle as the gas comes out. This is a common cause of loss of pneumoperitoneum. You put in a new instrument and you lose pneumoperitoneum. The reason for that is either the instrument doesn't fit around the port, there's no seal as it goes through that little washer, or there's a leak because this is open. So you've always got to check when you take one of these instruments that the port is closed. This is used for flushing out the shaft of the instrument, and is often not replaced. The other really useful thing that they have is this, and this enables you to rotate the instrument 360 degrees so that you can actually change the angle of approach of the scissors. And one of the things that people learn quite early on, or you should try and learn early on, is how manipulable your instruments are and how much you can move them, and in more than just two dimensions. So I think it's quite important to learn that, and it's a very nice little adaptation. And all the disposable instruments that you get will have this as well. Okay, except some of the clip applicators, most instruments will rotate through 360 degrees. Now, you'll notice here in my set of instruments that there's no needle holder, and that's because I very rarely sew, because most of the surgery that I do, apart from pyeloplasty and upper heminephrectomies, do not involve suturing. And I would suggest that when you start to do laparoscopy, you find procedures that don't initially involve a lot of suturing. Just get used to the instruments, take it one step at a time, and then move on to the more sophisticated things. And of course, if you're going to do radical prostates, you're going to be doing several sutures in each case. But work up to that slowly. Okay, this is the kit that you have at the end of the table. Now, so far you've seen laparoscopic videos that people have shown, and you've worked on the boxes, and so much of this kit is actually not there. But when you start working on the pigs later on today, then you'll see a lot more kit available. This is what we have in our theatre at Great Ormond Street. We have one monitor. Some people have 2 or 3 monitors. We have one monitor, and just like in an operation, everybody's looking at the same place. In our laparoscopic theatre, everybody looks at the single monitor. So we're all focused in the same direction. Everyone is looking together. Everybody's working in the same direction. And I think that's actually quite important. Although I've worked where there's been a monitor for the assistant and a monitor for the surgeon, it's very good to have the same monitor so you have the same focus. It's very strange in laparoscopy when there's more than one monitor, where you're working away and you're looking over here and your assistant is looking over your shoulder. It's very strange. You're used to looking at the same thing, and it's good, I think, to have one monitor. And for economic reasons, of course, this makes it very much more compact. Your laparoscopic equipment can be on one stack, we call it, and it can be wheeled in and out of the theatre when you use it. And we use this stack for our endoscopic work, so we use it for our cystoscopies as well. And if you buy sensibly, And of course, urologists will already have cameras and will already have monitors in their operating theatres, and if you buy sensibly, then you should be able to use these camera systems, which is probably the most expensive single item for all your endoscopic work, your percutaneous nephrolethotomies, your cystoscopies, and your laparoscopy. And it's really important to do that. When I was in Leeds, there was a problem because of sponsorship, as Ajmalin had bought a Storz set of instruments. But these were not compatible with our cystoscopes. And when it came to renew, there was a difficult decision. Should we buy cystoscopes to match the camera? Should we buy another camera to match everything else? So it's quite good to think about what you buy and make sure it fits in with what else you've got. But here we have a single monitor. This is a Sony. Most of the monitors are Sony Trinitron systems. And a variable quality. The smaller the monitor, the sharper the picture. If you get a really big monitor, then the picture can look really fuzzy, so you have to draw the balance. Don't get anything too big. Just get something the size of a modest domestic television, and it will work very well. You then have the light source, and the light source is normally halogen one, or inert gas, xenon one. And this works very well with a light lead. You can see the grey light lead attached. It's quite important with the light source to have some backup, because if your light source fails in the middle of an operation, you're completely stuck. So luckily, if you've got compatibility within your operating theatres, then you'll have several light sources. But don't make your laparoscopic one the only one of its type that you've got. Make sure there's another one available, because this quite often will fail through a bulb going or something like this, and it's a disaster if you're in the middle of a procedure. You then have the camera, and the camera comes in two configurations. There's the 3-chip camera and there's the single-chip camera. Now, the representatives will tell you how fantastic this 3-chip camera is, and often all the additional gizmos, all the sort of automatic functions are fitted onto that 3-chip camera, and the 1-chip camera, the single-chip camera, seems very basic. So when you look at it, and it's 25,000 euros for one, and it's 8,000 euros for the other, you think that the 3-chip camera must be so much better. Well, actually, I don't know if it is. And personally, if I was buying new, I would buy 2 single-chip cameras instead of 1 3-chip camera, because it's better to have 2 cameras than just one. Again, if one of them fails, you're lost. So I think you'll find difficulty in telling the difference in quality between a single chip and a 3-chip camera. And whilst if you had an unlimited budget, you clearly go for the more expensive, better quality one. The single chip cameras made by good manufacturers are very good, they're robust, and I use them, and it's difficult, to be honest, to tell the difference between them in terms of what you see on your television monitor. The CO2 insufflator is a very important piece of kit. This determines the flow of the CO2 and the safety and the pressure at which it's delivered to the peritoneum, or whichever cavity you're using. And it's quite important to know how this works. If you're in an operating theatre, you will find, I find this all the time at Great Ormond Street, even with people I've worked with for years, that something happens and you're stuck. As the surgeon, you're relying on somebody else to come and adjust the instruments. Don't let that happen. Take the time to learn how they work. So the bottom line is, if everyone is ignorant of what happens, you can sort it out. That's really important, because you are the one who is responsible for the operation. You are responsible for the well-being of the patient. And not to know how these basic pieces of kit work leaves you exposed to a disaster. So learn how it works. Learn that the pressure can be modified. Learn the safe limits of pressure around 10 to 15 millimeters of mercury for peritoneal laparoscopy is a good range, and in children we use 10, in adults you may use 15. But learn how that is adjusted and make sure that it's set right at the beginning of the operation. Learn about the flow. If you haven't got enough space, it may be because the CO2 is not flowing enough. Learn the indicator that tells you how much is in the bottle of the CO2, so that when you don't have enough gas in the abdomen, you can see whether it's the CO2 that's run out, whether the pressure is right, or whether there's maybe a leak And that leak is demonstrated by the fact that you cannot generate any pressure. Okay, now there's various things, and I haven't got a close-up picture of this, but on this basic Storz one, there's a green light here to tell you that you've got CO2 in your tank. There's a pressure, then there's a pressure indicator, and you pre-select the pressure, the maximum pressure that you want, and above that pressure it will turn off. Then there's a flow indicator, and in children I tend to use 1 litre a minute, but in adults you may use 5 litres a minute or so. You can adjust that. And then at the end, on the right, is the amount of CO2 that you've used. And if you've got a leak, then the numbers will keep changing because the CO2 is flowing through the peritoneum, and you see the numbers go up. You come to the end of the procedure, and when you do it in the pigs, if you've got leaky ports, you may come to the end of the procedure, you use 180 litres of CO2. Now, it should be possible to do a laparoscopic operation with modern port technology, with the seals that we have here, and with everything nicely fitting, to do a big operation with the loss of a minimal amount of CO2. So you could do, for example, a laparoscopic nephrectomy on less than 15 litres of CO2. Now, CO2 doesn't cost very much, but it is a complete pain when it runs out and you have to change the cylinder in the middle of an operation. And it also is difficult when you're trying to maintain the pressure inside the peritoneum if there's a leak. And the thing that will tell you if there's a leak is actually the CO2 amount that you've used just ticking up. So when you go to the animal lab, just have a look at the insufflator, see how it works, get a representative to explain how it works so that you're very familiar with it, because this is an essential piece of kit, and it's the piece of kit, I think, apart from the diathermy, which is obviously common to other operations, that people know the least about, and which most often will cause a problem. Video recorder. Now, I think it's quite good to record what you do, and probably from a medical legal point of view, it will be required in future that we keep a record of these procedures. It is extremely easy to video. If you're going to buy a video system, do not, I would suggest, buy a VHS system. They'll still be available, and you'll find you can pick them up very cheaply because everybody else is moving to the digital system with CDs or DVDs. Now, I started off with VHS, and I have a whole rack in my office just full of videos which I never look at, and one day I will burn them, and probably soon. But I think the CD and the digital thing is excellent, and particularly because you can put it straight in your laptop and you immediately got a video, a presentation, or to show the patient after the operation or whatever. And from a medical legal point of view, it may be necessary to store this on the system so that you can show, well, actually I didn't injure it, here's the video of the procedure, etc. But I think that videos are very good to look at afterwards, to think about what you were doing, to think about any difficulties that you had, to think about how you were set up and how you might change things. And it's also good to show things to colleagues afterwards and just review what you've done, and it's all part of the learning process. So video recorder is an excellent thing to have. This one we have here is very high quality, but rather old-fashioned thing. We're just about to move to a totally digital system. Now, when we undertake laparoscopy, we've got to remember our basic principles, which I told you the other day, but are worth repeating. If you decided to do laparoscopy, please don't do it because you want to do laparoscopy. Okay? Do it because you need to treat a patient, and laparoscopy is as good as the other way of doing it. Everyone's going to have a learning curve, and as a surgeon, you are responsible for shortening that learning curve by coming to courses like this, spending time with experienced colleagues, and maybe even having a colleague who you trust, who does a similar thing to you, but maybe is better at laparoscopy, to come to your operating theatre and show you how to do it. This is for the patient, okay? There's no place for pride here. It's for the patient. And so we must do our laparoscopy ultimately as well as a conventional procedure in order to justify to ourselves, morally and ethically, that we should be doing it. Don't do laparoscopy just because you want to do it. And it's got to be safe, so you can do anything laparoscopically. Someone told me once that a gynecologist could paint his hallway through the keyhole. Okay, gynecologists, of course, were the first people to do laparoscopic surgery. And of course, with the right instruments, you could paint your hallway through the keyhole. Okay, you need lots of long things, very thin paintbrushes. It will take you a very long time to do. It would be ridiculous when you could just open the door, step through, and do it with a conventional paintbrush. Now, it's exactly the same in laparoscopy, and although that's a ridiculous comparison, one has to bear in mind that sometimes the open surgery, the old-fashioned way, is the safest way to do it. Some nephrectomies are going to be difficult because of fibrosis, infection, and previous problems that the patient has had. Don't make that the one that you do laparoscopically. Okay, do it open. Save a nice little multicystic dysplastic kidney, the ones that are easy to take out. Make that your first nephrectomy, and then you'll enjoy it, and you'll do more. But if you do a difficult, horrible, and risky, worrying operation laparoscopically, it's the surest way to put you off it for life. Okay? So don't do it. Choose a safe procedure which has a low risk, and the laparoscopy itself does not increase the risk of the surgery. And let's make it practical and cost effective. You've got to do an operation in a certain amount of time. You can't use your operating theatre for doing a minor procedure for the whole day when you've got 5 patients with bladder cancer that need their TURBTs. Okay? So make it practical and cost effective. And I think in this, as a surgeon starting out on laparoscopy, you must be prepared to open the patient. Okay? You must be prepared to open the patient. Everybody does it. Everybody has done it. And Dr. Gill, even then you saw a patient that he was operating where the patient had to be opened. It happens for various reasons. You must be prepared to do it, and the patient must be prepared for that to happen. Okay? Because that's what makes it safe. Proceeding with a difficult laparoscopic procedure is not a sensible idea. Sometimes you have to say, we can't do this laparoscopically for whatever reason, we're going to open it up. And that is perfectly and absolutely 150% acceptable. I've done it, everyone's done it. There's only 2 types of surgeons with laparoscopy, those that know their limitations and those that don't. And the ones that don't know their limitations and proceed to try and do everything laparoscopically are dangerous surgeons. And let's hope we have none of those in this room. So what safe techniques are we going to use for laparoscopic surgery? Well, first of all, I always put the first trocar ring open. Okay, I actually take out, I should have said port, because the trocar is a sharp bit in the middle. This is a dangerous thing. So when you go in, I always put it in blind. You have to put it in blind. There's no way you can see inside what you're doing. So I always make a direct incision, whether it's a retroperitoneal nephrectomy, whether it's a transperitoneal nephrectomy, whatever it is, I will open the peritoneum and place this inside, and then secure it with a stitch in the right position. And this is the safest way to do it. People use a Verres needle, and you'll probably have Verres needles. I was handed a Verres needle, so I suspect the surgeons here use Verres needles. I would just suggest, because the Verres needle is a dangerous thing, apart from the trocar, the Verres needle is the next most dangerous instrument on the set. So I wouldn't use it, okay? Unless you're confident and you've been trained well to use it, in which case perhaps, it's no longer a point of discussion. If you're starting laparoscopy, don't use a Verres needle. Put the first port in open. It may take a bit longer, but it's always safe. Always safe. And safety is the first and the biggest word in laparoscopy. I use these low insufflation pressures. If you insufflate at a high pressure, there's 2 problems that you have. First of all, through stretching the peritoneum, the patient will have more post-operative pain. And if you're doing a peritoneal laparoscopy and you stretch the peritoneum at 20 millimeters of mercury, they'll complain of pain from stretching the diaphragm in their shoulders, and it can be very uncomfortable and nasty for the patient. So keep the insufflation pressures low. When you look at the insufflator, if you notice during the operation the pressures go very, very high, very, very high, there's 2 possible causes. Either you're tubing from the CO2 insufflator to the patient is kinked, and when it's kinked, the CO2 can't flow, so the pressure surges. That's the first thing. So you can check the tubes to make sure they're not kinked, to make sure the CO2 has a clear passage, all the taps are open, and it's open to the patient. The next thing, though, and probably more important, is if the patient is not relaxed and their valsalva are moving like this, and they're tensing their abdominal muscle, the pressure will surge, And the instruments, because they cannot release CO2, will actually be powerless to assist you, but the pressure will go very, very high. This is dangerous. Okay? This is dangerous. If you've got any veins open or whatever, you can cause a CO2 embolus, or you can cause a rupture of the peritoneum, you can cause all kinds of problems with the patient not relaxed. So the patient has to be very, very well relaxed during the laparoscopic procedure, and you have to stop, open the ports, let the CO2 out, and get the anaesthetist to relax the patient with muscle relaxants. It's very important. So with a patient well anaesthetized, and one makes this assumption, but unfortunately you can't always do that, use a low insufflation pressure. If you have to use a high pressure, then there's probably something wrong with the way you're doing the operation. I always put the supplementary ports in under vision. Okay, when you're putting in an extra port, you look at the abdominal wall, and when you put in a port, hold it like this. Okay, hold it like that. Okay, in your hand. One thing I didn't show you about the Stork's ports, they've got a hole here. Why is the hole there? If you look at the end of the trocar, there's a little hole there. Can you see? There's a little hole inside. When this goes into the abdomen, gas comes out and you can actually hear it whistling. Okay, so when you've got it in with the trocar, your pneumoperitoneum will disappear unless you take this out. Okay, because there's a hole. But that's intentional, because you're meant to be able to feel the gas or hear it whistling out when you're in. Because you're always going to be watching it go in, this is an irrelevance, but it's something that can cause loss of pneumoperitoneum, so just be aware of that with these ports. But I always hold it like this, okay? And the reason you hold it like this is because if it slips, it's only going to go in about 3 centimeters, all right? If you hold it like this, and it slips, it's going to go in the whole length of the instrument. Okay, so whatever ports you're using, always, always, always hold it like that, but with your finger here, so that it can't go all the way in. You know, I was in Cambridge when they were starting laparoscopy. A patient died because a port was inserted, it went straight through common iliac artery. By the time they'd opened the abdomen, the patient had exsanguinated. Now this was a fairly fit lady having a gynecological laparoscopy. That's a complete disaster. These instruments are dangerous. I don't want you to be scared of them, I just want you to be aware. You know, I think one of the principles of surgery, safe surgery, is knowing before you do anything what you can do wrong. How can I really screw up today? Okay? And as long as you have that in mind, you won't do it. But as soon as you start thinking, oh, this is easy, I'm great, then the next thing that happens is a major complication. That's what I found. And I think that we have to be aware of what can happen. Absolutely. So, I tend to hold it like this, and then when I'm coming into the abdomen, I've got my vision port, I put this in open, so it's nice and safe, and I place my other port here, and I can see it coming through, yes? And I can see that there's nothing around, and there we are, we're in. And that's safe. Okay. If you're going to do a laparoscopy in the abdomen, you've got to have a good anaesthetist. And there's a couple of things that you can do to avoid the other things in the abdomen taking up too much space. One of the things that takes up the space, the main thing, of course, is the gut. And so you've got to stop the gut from filling up. And there's two ways of doing that. First of all, you can empty it a little bit beforehand. And for pelvic laparoscopy, it's very helpful to give the patient an enema a few hours before the surgery, so they open their bowels, the rectum is empty, and the left colon is empty. And this is particularly useful if you're doing pelvic surgery, or if you're doing a nephrectomy, a left nephrectomy in particular, where you've got to move the left colon out of the way. The other thing is that the anaesthetists, particularly in children, pre-oxygenate the patient before they intubate them. Alright? They put a mask on, they tip their head back, they open the airway, and they bang. Now in a child it's very easy, because of the way that the glottis is organised, to actually just inflate the stomach when this happens. And this stomach air fills up the upper abdomen, and then it passes through into the small bowel, and you end up with a whole pile of sausages in the abdomen, and you can't see anything. Alright? So if you try and encourage your anaesthetist not to do that, not to pre-oxygenate the child, not to bang them beforehand, then you can avoid this distension of the gut. Along the course of a long operation, nitrous oxide accumulates in the bowel as well. So really an anaesthetist has to deliver a special anaesthetic for a laparoscopy. And if your anaesthetist is experienced and he's worked with a colleague, then you'll be fine. But if he's never done laparoscopy, perhaps like yourself, then he needs to think about what he's going to do. It's not going to be a standard anaesthetic. For most anaesthetists this is familiar, but you have to check that yours is familiar too. Or else your operation will be difficult, and although technically you could have done it, this will cause you to open the patient. So it's well worth thinking about it. And of course in the pelvis, and as urologists we know that we can damage the bladder, so we empty it. And in the child, I'd use lower abdominal compression or the Crede manoeuvre, and that empties the bladder quite happily. Alternatively, you just put an in-out catheter, or you can put a Foley catheter in, depending on the procedure that you're doing. So let's talk a little bit about positioning the ports, because obviously you're going to have access to various parts of the body, and you've got to decide where you're going to put the instruments in. Now when you put the instrument into the body, you create a fulcrum for the instrument, and the instrument will be fixed at the point of entry of the body, and you'll be moving around that point. It follows if you don't choose that point carefully, then you're going to be in trouble from axis, and it may be then that you have to put the port in another position, and you're making more holes. Now one of the ways that laparoscopy is being justified to patients is as a smaller scar. But if you put 6 different ports in and you add up the lengths of the scars, it's going to be longer than your conventional surgery. So that argument is rather defeated. So you need to choose your port sites. If you choose them badly, the operation will be difficult. But conversely, if you choose them sensibly and well, then the operation will run smoothly and it won't be a problem. So let's look at a little bit of port position. Now, I tend to use an abdominal port, so the first port is always the umbilicus for me, and I think it's the easiest place to place a port, particularly in an adult. And if you take a cross-section, if you look at CT scans, those sagittal sections that you sometimes get given, and you look at the umbilicus, it's always the thinnest part of the abdominal wall. Okay? It's just fascia at that point, there's no muscle, and so if you go just below the umbilicus, you're going through a rather thin area that's quite easy to access. And this is the best place to put the Hassan port. Now you can place it just above, just to the side, or just below the umbilicus. And I place it in all places, but for pelvic, actually, unlike this picture, I tend to place it just below the umbilicus. And if you place it in the skin crease below the umbilicus, when it heals up, you don't even see it. So that's another bonus for that site. Now, the other sites, you have to bear in mind that there's a few things that you must not puncture with your port. And the main thing in the abdominal wall is the inferior epigastric vessels. Now you can see these below the arcuate line, just below the umbilicus, because the posterior wall of the rectus is not fascia, is it? It's just peritoneum. And so you can see the muscle, and you can see underneath the peritoneum, you can see the arteries. And I showed you that at the theatre the other day, that you can see them. And you mustn't pierce those, because they'll bleed, you've got a hematoma, and they could stop you from succeeding in your operation. So you tend to choose a place that is lateral to the rectus muscle, just lateral to the rectus muscle, and you can see that under direct vision from below. You just poke with your finger, you can see where your finger depresses the abdominal wall, and you place your port in that position. And it tends to be the left or the right iliac fossa, and I would tend to place, if I was doing a bilateral orchidopexy, for example, I would place the 2 ports here. If I was doing gynecology or excision of malarial remnants or something like that, I would put them both here. If I was operating on the right side, I might place a secondary port in the midline. Okay? So I've got 2 ports to work towards this side. But if I want to work this way and this way, then I'll place 2 symmetrical ports, which gives me access to both sides of the pelvis. The other thing that you need to do to help you, of course, to move things out of the way, is you can put the patient's legs up, the transdental bow position, then the gut will fall into the upper abdomen and you'll get more space in the pelvis. And this is completely essential. Of course, conversely, if you put the head up, then you're going to lose everything because all the small bowels will fall into the pelvis and you won't see a thing. No matter how good your pneumoperitoneum is, the bowel will move. So try and move it out of the way by using a little bit of table movement, tipping the table up. Okay. And here's the signs for a patient. This patient's got hypospadias, which I've fixed already, and is having a laparoscopy to remove a big utriculus masculinum. Now, a couple of things to point out here. These disposable ports, so the reusable ports, where's it gone? These reusable ports have a sort of a matte finish on the outside. They don't have, you can get various things that help to hold them in, and those things include screws and other things that go on the outside to try and fix their position. However, you can fix their position very, very simply with just a standard suture and a steri-strip. So what I tend to do in the umbilical port, I've got a purse string. I put a purse string around the hole that I've made, which enables it to seal around the port and also enables me to close it afterwards. I tie the string around the tap. Okay, you put a stitch through and you bring it up, you cross it over around the instrument and you tie it above the tap, and that stops it from pulling out. Okay, it stops it from pulling out. This is a pain if it pulls out. It's not a disaster, but it is a complete pain. If you then place a little steri-strip around the port, close to the skin, around the suture as well, then it will stop the port from slipping in. So with a very simple thing, you can use this reusable port and you can fix the position of the port exactly so it's not slipping in and it's not coming out. And it's quite important to do that, particularly if you've got limited space as in a child. Always try and work in line. Okay, if you could see the pelvis, you would look at it and you would work in line with your body, along your arms, in the pelvis. So, if that's what you're going to do, and your eyes would normally look in this direction, keep them looking in the same direction by placing the monitor at the foot of the table. So you're looking along the line of your arms. It's the easiest way to work. You can't work like this. I'm sorry, you can't do that. Alright? Even if you're working straight, you can't have your head like this. It's very, very uncomfortable. So put it at the end of the table. And if you've got one monitor, it's the more important to have everybody working in line with their arms, and it's something that you'll discover with the pigs. Try moving the monitor around, okay? You'll find if you've got the monitor fixed at one end of the table and you're doing something that involves looking sideways, it's very uncomfortable, it's very difficult. Turn it 90 degrees around, move the monitor around so it's in front of you, and it becomes easier. Okay? You've not changed anything about the patient, you've just changed the way that you're standing, and your brain works better when it's working in line. Okay? It doesn't work well at 90 degrees to the rest of your body. So put the monitor at the end. So in a pelvic laparoscopy, it will be at the end of the table by the patient's feet. Now the light lead is sometimes a limiting factor. Okay? The light lead is often the shortest thing that you've got. So it's quite important in that situation to actually get the patient right up to the end of the table and to make sure you've got a decent length of light lead so that you can actually reach to your instruments higher up. This is a transperitoneal nephrectomy. This is how I did the first 31 nephrectomies. And you place the patient in a lateral position, obviously with the side of your operation upmost. The abdominal port, the first port is at the umbilicus, and I tend to use a bigger port for that, and there's a very nice disposable one. This comes with a terribly effective trocar. I mean, this is a very, very dangerous thing. Okay, and actually Storts do provide these with a blunt trocar. Okay, a nice dome-shaped blunt trocar. And if you're only going to use this for your first port, then you don't need this trocar. You just get yourself a blunt one, and you can put it in very safely. Alternatively, you just take the trocar out. But the nurse will always hand you the port, with a trocar in it. I don't know why, but they always do, even though you're not going to use it. So it's very, very important to make sure that you look before you just place it in. Anyway, I'd use a 10mm trocar in the umbilicus and two 5mm trocars. Again, these are along the lateral edge of the rectus sheath, so you're away from the inferior epigastric vessels, and they give you quite good positioning. And the vast majority of patients, you can do this laparoscopy with 3 ports, even for quite a complicated nephrectomy. If you need a different vision, if you can't see very well from this position, you can place a supplementary port here in between your 2 working ports, and that is one way of making things easier if the operation is difficult. But for the most part, you just use the 3 ports. If the patient is lying on the lateral aspect and you're working from one side, your assistant will stand next to you, your scrub nurse will stand next to him or her. Your monitor is behind the patient. So here you are, the patient is here, you're working across, and the monitor is there. So you're working in line all the time. Okay, so the instrument selection we've talked about. Try to get used to using basic instruments. These graspers are very simple for manipulating. Get yourself a basic manipulating grasper, and be careful. Now, one of the good things about laparoscopy as opposed to the robotic surgery is in laparoscopy you get feedback through the instrument of how hard you're pressing. Okay, it's not as good as a direct hand instrument, but it nonetheless gives you feedback. And bear in mind that a lot of the things that you're using, a lot of these graspers, you would never use anything like this, for example, for picking up the bowel. You wouldn't. So don't start doing it when you become a laparoscopic surgeon. Be safe. Okay. So, how do we do the dissection? When you're in there, you can use scissors. Okay, that's obvious, that's what we use for open surgery. And you can attach diathermy to the scissors as well, which gives you a little bit more flexibility. You can use the harmonic scalpel, which some surgeons in your hospital may already have, and I love it because it's pretty safe, it's very effective, but it generates smoke. Both of these things generate some sort of smoke. The scissors, if you use diathermy, generates real smoke. The harmonic scalpel generates sort of steam inside and particles floating around, which you sometimes just have to let the neuroperitoneum go to let the particles out. The diathermy hook is another very good thing to use, although I think it's one of the more dangerous ones. It does work very well. And here we can see the scissors. This is a multicystic dysplastic kidney, and the scissors here. Now, the one thing to learn about the scissors, and I had to try to stress this with some of you before, is that they have not only a bare tip, but a variable amount here outside the instrument of bare metal. If you're in a very small space and you're looking very close up to apply the diathermy, you won't see the whole of that metal. And it is just possible that outside your field of view, a small bowel is up against the instrument, and it will get burnt and doused. So it's absolutely vital that when you apply diathermy, and I'll talk about it in a minute with diathermy, that you actually see the whole exposed area of the instrument, the whole diathermy electrode, if you like, and you're not unwittingly out of your field of view causing an injury to the bowel or some other structure. So how do we secure vessels? You can use clips. There's some very nice clip applicators. The ones I think we've got here are 10mm clip applicators. And because of that, you've got to choose a 10mm port. Alright? It's all very well putting a load of 5mm ports in and then finding out that your instrument you want to use, normally a disposable instrument, is 10mm. You've got to design your ports according to the size of your instruments, but they make a very nice 5mm clip applicator, and it's very much more versatile. And if you have the choice, that's the one I would choose. You can use diathermy to secure vessels. It's good. Clips are good for fairly big vessels, like in a nephrectomy. Diathermy is not as reliable, and I would use it for small vessels, but I wouldn't use it for big vessels. It is a little bit risky. The harmonic scalpel, my gynecology friends tell me that you can divide the ovarian pedicle very easily in a mature woman with the harmonic scalpel, and I've seen them do it. But I've had a problem with the renal artery where I actually coagulated it along quite a considerable length before dividing it with a harmonic scalpel, and then subsequently the patient bled. So I had to open it and tie it off. And that's my one conversion of the laparoscopic nephrectomy. So now I always use clips because they're safe and they work well. Or, of course, you can ligate. You can ligate, you can use a tie, you can tie a knot. It takes more time, and probably it's not as good as if you do it open, so I would prefer clips. And here's a clip applicator. This is a nephrectomy. Here's the ureter, here's the kidney, and this is the vein. And we've got a selection of clips. This is actually 3 or 4 clips on the vein. I always place 2 clips inside and 1 clip to the specimen. Okay, so I put 3 clips. 3 clips proximally on the vessel and 1 clip distally, and I cut between them, leaving 2 clips afterwards. When you see a vessel like this, you've got to make sure that you go beyond the edge of the vessel. And you can see this clip doesn't quite go to the edge of the vessel. This could bleed. The second clip goes right to the edge of the vessel. You've got to try and see that the clip is round the vessel before you trust it. Now there's various other powers that we can deliver. Diathermy can come in 2 different forms, monopolar and bipolar, and then there's the harmonic scalpel. And those are the main things that you tend to use. We're all quite familiar with monopolar diathermy, and it's the main and the easiest one to use. Anything else requires additional instrumentation. But bipolar diathermy is very safe because it applies the current at the point of contact and doesn't conduct through the body, doesn't conduct through the instrument, and therefore you're not placing the patient at greater risk. So it's quite a nice thing to have, but you need special instruments to do it, and they're not always very well designed. I think the harmonic scalpel is a very good thing to have, but it's not a great panacea. It doesn't always work very well, and you've got to be aware of its limitations before you use it. It's also incredibly expensive. This is a patient having an orchidopexy, and I showed you the other day, putting clips on, but you can use this instrument, bipolar diathermy, just to divide the vessels, and it works pretty well. And that's sort of small vessels. The bipolar works very well indeed, although I don't like the instrument. Here we see again the bipolar diathermy being used to divide vessels. This is the before, these are the vessels to the testis, and this is the after use of the bipolar. And here we see the bipolar being used for slightly bigger vessels. Now it does work, but we've all used diathermy on the patient in open operations, so you know you just buzz it once and you cut the vessel and it bleeds. Well, it's quite easy to go back with open surgery and buzz it again, isn't it? After losing 5 mils of blood, that's not a problem. You just mop it up with a swab and it's fine. In laparoscopy, if you lose 5 mils of blood and the field becomes red, it absorbs the light, you don't see as well. It's more difficult to wash things out and to get a good view again. So just use clips. You use clips, your work's going to drop and it'll make it better. Now, when you've done your operation, you've got your testicle, your ovary, your whatever you've removed, your kidney, you have to take it out. And of course, this is where some laparoscopists were criticised because they use these very, very small holes to do a nephrectomy, and then they make a great big hole at the end to take the kidney out. Okay. There is some evidence that in spite of that, the patients still do better. But my preference is to take the kidney out whole if it's a dysplastic kidney, and you can stretch up the biggest port and pull it out that way. That's great. Or you can morcellate it. You can either cut it up inside and pull it out in chunks, or you can use something like an electric mixer to mix it up, which I don't use and not many people do. I like to catch it in a basket. I showed you a basket in my 2 videos the other day, and no doubt you'll see them when you operate on the pigs. They're very nice. They're like a big fishing net. You put them in through a 10mm port. You deploy them. It's literally like a fishing net. There's a metal hoop that opens, and you just place the thing inside. There's a drawstring, and you pull, and it ends up like in a little purse. And you pull the purse out through the hole, and then you can just stretch the hole to deliver the whole thing through. And it's a very nice way of doing it. Or alternative, you can make the decision to do it, which seems a little bit defeatist when you try to prevent big holes being made. Now, the one situation in which you will make an incision is if you do a donor nephrectomy, or if you're taking out a decent-sized tumour and you don't want to break it up. But a donor nephrectomy is the classic operation where you need to be incredibly careful because you want to keep this kidney. Obviously, it's going to be given to the son or the daughter of the patient. And in that situation, you mobilise the kidney laparoscopically, then you make an incision, reach in, and take it out carefully. And that's perfectly acceptable, and the patient seems to do a lot better in spite of the fact that they've needed another incision. The other thing with the nephrectomy is the standard approach for nephrectomy is a line incision, which is a very, very painful incision. And I don't know if anyone's ever had one, but it takes a while to recover from that. But it would be better for those patients if they had a flap and steel incision, which correspondingly or conversely heals up very nicely and is not a problem to the majority of patients, of course, women with caesarean sections are walking around the next day. So, in that situation, it will be an advantage to mobilise the kidney through a laparoscope and take it out through a less painful incision at the end, and you still maintain the advantage of doing it laparoscopically. Now, just a few little tips. If you lose your pneumoperitoneum, you've got to go through a checklist, because if you lose the gas inside the tummy, you can't see a thing. It's a nightmare. You can't do anything. So, the way to deal with this is, first of all, check your CO2 supply. Have you run out of gas? Is the insufflator on? Okay? Is the initial point of delivery of the CO2 okay? Then check the connections of the CO2 to the patient. Are the tubes connected? Are they kinked? Are they open? Is there anything blocking them? Are they all joined up? You'll know if you've lost CO2 because it's leaking, because the number on the insufflation will be going up. And look at that when you see the patient, the pigs later on. Look at the insufflation and look at the numbers on the right-hand side. And if you can do the procedure you're doing with a relatively small increase in the numbers and you've saved CO2, you've got no leak. If you've got a leak, then you'll see the numbers going up. But check the tubes are connected and check the taps are on. Now, most insufflators have got an alarm. Again, test it. I always test it. When I connect the patient, I'll connect the CO2 and I'll keep the tap on the port closed. So there's no way the CO2 can flow. With the instrument on, pumping CO2 and the tap closed, the alarm goes off. And that tells me that the alarm is working. I always like to test that. So if the alarm goes off, then you know it's working, you open the tap. Make sure all the taps are open. Some insufflators don't have that alarm and they won't tell you that there's a blocked tube. Then check for leaks. Now, the commonest sites for leak is at your port site, perhaps the first site you've put in. You've made an open incision, it's a rather big hole. The port doesn't fit very well. The way to prevent that is using a purse string around the hole before you put the port in. But make sure the port sites are healed. That's the first thing. Then look at the port and make sure that the washer in the port is appropriate for the size of instrument. Okay? If I place this instrument through this port, it's perfectly possible to do it. It's perfectly possible to do it, but you can see there's a great big space around it, and there's no way that there's going to be anything other than complete loss of pneumoperitoneum. Now, that's pretty obvious, isn't it? But there are, for the smaller ports, two different sizes of washers and slightly differing sizes of instruments, and you just need to make sure that the washer that you've got on, just a piece of rubber, that's all it is the right size for that instrument. And then the leak through the instrument. I showed you the tap on the side, in particular, any little bits of washer missing on the instrument itself can be a cause of a leak and an absolute pain, unless you just see it and just put the tap on and it's done. Okay. Safety. Now, I think the one word I want you to take away from today is safety. Safety, 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 safety. If you're going to make a mistake, make it on the pig. All right? I think I told some of you the story that the lady actually in that first picture was learning laparoscopy. We gave her a pig to operate on. She put the first trocar in, flew straight through the liver, through the duodenum and into the kidney. Whoop! Okay? She didn't place the port safely. She killed the patient. It was a dead pig. We don't operate on anaesthetised pigs in the UK. We're not allowed to. So they're freshly slaughtered, and we operate on them within a couple of hours of their death. so the blood still flows. If they give a bit of heparin, it doesn't clot. And we get a simulation, not a brilliant simulation of a live animal. But in the live animal, the animal would die. Boom. So she was a bit upset about that, but it taught her the danger of laparoscopy. You have to be aware of the danger of laparoscopy in order to be safe. So always put the first port in open, place the further ports under vision, and when you place the instruments in, I want you to place them under vision too. And what do I mean by that? I'm afraid the camera's playing up a little bit. When you're inside the abdomen, there's a lot of other things around. And if you're working down in the pelvis and you're placing other instruments in and out to access the pelvis, you won't see the ports, which are literally, if you consider your face at the tip of the camera, the ports are up here. And placing instruments in and out of the ports, you will not see where they are going. So you can go through the omentum, you can go through the bowel, you can make all kinds of injuries to the patient, particularly if you're not quite aware, and it takes a little while of getting aware of the direction that the instrument needs to go in. So to save that danger, for the first few times that you place an instrument, I want you to look and go through the habit of it, of looking at the tip of the port, identifying where it is, watching the instrument being passed. So like this. You place the instrument in the port, you get the camera to look, and you watch the instrument all the way down to where you're working. You can take it out okay, and then when you put a different instrument in, go back to the port and watch it. Now, when you're doing an operation, when you're doing an operation, you'll get used to the position of your instrument, and you'll get used to going in and out and back to the same place. But it takes a while to get orientated. Some people get orientated very quickly, and for others it takes a long time. But it's a very, very good discipline when you're placing the instruments in to the port to follow them down. There's nothing wrong with that. It's very safe. And it's absolutely important for the patient that you're paranoid about the danger of doing that blind. Diathermy is dangerous. It's monopolar diathermy we're really talking about. And there's two things, that one of which I've already told you, is that if you're applying diathermy anywhere in the patient, you must always see all active parts of the diathermy instrument. If you use these metal ports, which are excellent, and I use these for every case that I do, there's another danger. If you apply diathermy down the instrument, but you don't earth the instrument or touch the patient, in other words, you're not actually touching what you want to burn. You can see the whole electrode, there's nothing being touched, your foot is on the pedal, you will create a charge inside that instrument, an electric charge. Now, the instrument is inside a metal cylinder, which acts like a capacitor, and on the outside it generates an opposite charge. And this is called capacitive coupling. And it is possible, even though the instrument is insulated, even though it's not touching any metal of the port, it's possible to create a burn around the port that goes all the way through the thickness of the abdominal wall. Now, when you've operated on the pigs, you may find, a couple of you, that you see these burns. If you're using metal ports, you possibly use plastic ports. It can still happen with plastic ports. You get a burn. So it's very important, if you're using diathermy, that when you use it, you keep the foot off the pedal until you want to apply it. You don't put your foot on the pedal and then move the instrument. You touch with the instrument and then apply it very carefully. And if you're paranoid about diathermy, not scared, but just very, very careful, then it'll be safe. But capacitive coupling was something that was discovered early on in the days of laparoscopy, and many people got burnt, and it was a common complication until it was described and people stopped doing it. Okay. So, just a few words, just very, very basic things for starting out, which I've said already. When you're starting out, choose basic instruments, get familiar with them, get good with them, and then get more sophisticated. Don't go for the most sophisticated, difficult instrument to start with. Start easy and get more complicated. As you get more competent and more competent. Choose simple procedures. Don't go straight in to do a radical nephrectomy.